India is an ever-growing country of 1 billion+ people and one of the world's fastest-growing economy with a thriving middle class. The present skilled workforce in India is only 2%, which is much lower when compared to the developing nations. Today, if we look at the human resources in the government health sector across the country, India faces an acute shortage of health personnel. Together with inequalities in distribution of health workers, this shortfall impedes progress towards achievement of a functioning health system. Traditionally, our Indian health system has been doctor-centered. If we look at every level from the PHC to hospitals, it is managed by clinicians. There has been a debate on whether we should train a cadre of doctors as managers and administrators. In 2005, to address this managerial concern, under the National Health Mission, it was decided to introduce program managers at the state, district, and block level. Though these program managers were introduced into the health system, they had no idea of their role in the public health system.
So when we interacted with them way back in 2009, 2010, though it was nearly 5 years since NRHM had started and since they had been put in place, they did not even know basic things like what is an antenatal, how do you define an infant, what is infant mortality rate, how do you calculate it. They did not know how to monitor indicators, etc. So they were just, we found them in Karnataka, especially in a district called Tumkur. We found them basically as glorified data entry operators and collectors of the utilization certificates from various PHCs.
In collaboration with the Government of Karnataka and support of Institute of Tropical Medicine, Antwerp, 150 block program managers were trained across the state of Karnataka in over 30 districts. The main role of the block program managers was to manage the national programs and monitor the performances. The other responsibilities was to give feedback to the medical officers, taluk health officers, and district officers. They were also expected to keep accounts, especially untied funds. As they were management graduates, they had basic knowledge of managing accounts.
ಆ್ಯಕ್ಚುಲಾಗಿ ನಾವು ಆ್ಯಸ್ ಎ ಬಿ ಪಿ ಎಮ್ ಆಗಿ ನಾವು ಡಿಪಾರ್ಟ್ಮೆಂಟಿಗೆ ಸೇರಿದಾಗ ಬಿ ಪಿ ಎಮ್ಸ್ ರೋಲ್ ಏನು ಅನ್ನೋದೇ ನಮಗೆ ಗೊತ್ತಿರಲಿಲ್ಲ.
ಸೊ ಸ್ಟಾರ್ಟಿಂಗಲ್ಲಿ ನಮಗೆ ಐಡಿಯಾ ಇರಲಿಲ್ಲ. ಸೊ ಯಾವ ಪ್ರೋಗ್ರಾಮ್ ಹೆಂಗೆ ಮಾಡಬೇಕು, ಯಾವ ಇದು ತಾಯಿ ಮಗುವುದು ಅದ್ರದ್ದು ಬಗ್ಗೆ, ಇಮ್ಯುನೈಸೇಷನ್ ಬಗ್ಗೆ, ಆಮೇಲೆ ಸರ್ವೆಲೆನ್ಸ್ ಬಗ್ಗೆ, ಇದ್ರ ಬಗ್ಗೆ ಏನು ಐಡಿಯಾ ಇರಲಿಲ್ಲ.
ಆ ಸ್ಟಾರ್ಟಿಂಗು ನಮಗೆ ನಾವು ವರ್ಕ್ ಮಾಡ್ತಾ ಇರಬೇಕಾದ್ರೆ ನಮಗೆ ಗೊತ್ತಿದ್ದು ಒಂದು NHM ಪ್ರೋಗ್ರಾಮಲ್ಲಿ ಯಾವ್ಯಾವ ಪ್ರೋಗ್ರಾಮ್ಸ್ ಬರುತ್ತೆ, NHM ಓನ್ಲಿ NHM ಅಲ್ಲಿ ಏನೇನು ಬರುತ್ತೆ ಅಷ್ಟು ಮಾತ್ರ ನಾವು ಸ್ಟಿಕ್ ಆನ್ ಆಗಿದ್ವಿ. ಅದ್ರ ಮೇಲೆ ನಾವು ವರ್ಕ್ ಮಾಡ್ತಾ ಇದ್ವಿ.
With limited resource settings, logistics, and trying to cover a large geographical area, e-learning was a promising way forward to help build the capacities of the block program managers.
So we did a couple of pilot programs where we tried to translate existing face-to-face tested training programs into an e-learning format. And these early pilots were very helpful in sharpening these programs and sharpening the pedagogy, sharpening the ability to use the learning environment. And with these initial success stories, we were really able to take e-learning to scale. So that is the program where we tried to have a blended training program for block program managers of the government across the state. And the project has been received amazingly well by both by the managers at the state level as well as the beneficiaries, the students across the state.
To make our course interactive, we have used various methods. Especially, I would like to highlight tutoring. Using tutoring, we are really able to interact with the students on a one-on-one basis by using the help of mobile phones, which really created a personalized learning experience for the participants. And if you look at the entire course structure, it's structured in a way that the students are easily able to navigate, and it is gamified in a way that it gives a personal touch to whatever they do.
With constant support throughout the course, the training team at Institute of Public Health managed to bridge the gap between online learning and face-to-face classrooms.
ಡೆಂಗ್ಯೂ ಬಗ್ಗೆ, ಕಾಲರಾ ಬಗ್ಗೆ, ಎಲ್ಲ ಪ್ರೋಗ್ರಾಮ್, ಸರ್ವೆಲೆನ್ಸ್ ಬಗ್ಗೆ, ಮಲೇರಿಯಾ ಬಗ್ಗೆ, HIV ಬಗ್ಗೆ ಪ್ರತಿಯೊಂದಾಗಿ ಡೀಟೇಲ್ ಆಗಿ ನಮ್ಗೆ ಅಲ್ಲಿಂದ ಮಾಹಿತಿ ಸಿಕ್ತು. ಸೊ ಹಾಗಾಗಿ ನಾವು BPM ಅಂತಂದರೆ ಇಷ್ಟು ಎಲ್ಲ ಪ್ರೋಗ್ರಾಮ್ಸಲ್ಲೂ ನಮ್ಮ ಒಂದು ಇನ್ವಾಲ್ವ್ಮೆಂಟ್ ಇದೆ ಅನ್ನೋದನ್ನ ಇಲ್ಲಿ ನಮಗೆ ನೀಟಾಗಿ ಕ್ಲಿಯರಾಗಿ ತೋರಿಸ್ಕೊಟ್ರು ಈ ಲರ್ನಿಂಗ್ ಕೋರ್ಸಲ್ಲಿ.
ನಾವು ಇವಾಗ ಅದನ್ನು ಕೋರ್ಸಲ್ಲಿ ನಮಗೆ ಅದರ ಪಾಯಿಂಟ್ಸ್ ಹೇಗೆ ಅದನ್ನು ಅನಲೈಸ್ ಮಾಡೋದು ಅದನ್ನು ಹೇಳ್ಕೊಟ್ರು. ಸೊ ಅದನ್ನು ತಿಳ್ಕೊಂಡ್ಮೇಲೆ ಸೊ ನಾವು ಕ್ರಿಟಿಕಲ್ ಏರಿಯಾ ಅಂದರೆ ಇವಾಗ ಮೆಟರ್ನಲ್ ಡೆತ್ ಎಲ್ಲೇ ಆಗೋ ಚಾನ್ಸಸ್ ಇದೆ, ಆ ಏರಿಯಾ ಹೆಂಗಿದೆ, ಪ್ಲಸ್ ಔಟ್ಬ್ರೇಕ್ಸ್ ಆಗೋ ಚಾನ್ಸಸ್ ಎಲ್ಲೆಲ್ಲಿ ಬರುತ್ತೆ ಅನ್ನೋದನ್ನು ಸ್ವಲ್ಪ ಡೀಟೇಲಾಗಿ ಅದ್ರಲ್ಲಿ ಗೊತ್ತಾಯಿತು. ಸೊ ಅದ್ರ ಪ್ರಕಾರ ನಾವು ಇಂಟರ್ನ್ ಇವ್ರಿಗೆ ನಮ್ಮ PhD ಲೆವೆಲ್ ಅವರಿಗೆ ಇಂಟಿಮೇಷನ್ ಮಾಡೋದಕ್ಕೆ ತುಂಬ ಅನುಕೂಲ ಆಯಿತು.
If we want to revolutionize the Indian health system, we need to have a critical mass of people who are updated about the latest understandings on health systems, etc., and are able to make the change. And for this, we have to use technology. There's no way that we can forget about technology, because technology gives us a tremendous opportunity to reach out to a lot of people.
Technology is a very, very important part of healthcare, and not only in its own more orthodox understanding of drugs, vaccines and so on, but today I think health communications and the whole technology of health communications is becoming very, very important. But I think one has to be a little careful as one begins to introduce and reflect and try and initiate projects in technology, because there is a tendency in medicine which is a very high, and public health which is often very hierarchical. But I think health communication and the use of IT and all its related complexity and potentiality can be very much a two-way process, where not only are experts and service providers being informed of the challenges and the latest understanding of different problems, but the context of the problems, the experience of people and their culture and how it affects the use or the misuse or the non-use of technology can also be fed into. So I think health communication must always be seen as two-way, where the health communicator is like standing between the system, the provider, the expert and the community. And when that is done, then I think health communication can reach its full potential.
So all this said, while technology is an amazing opportunity at realizing these innovative training programs, I think technology has to go very carefully along with system building. So the more and more we invest in building government health systems and services that are robust, that are resilient, the more and more will it improve the environment where technology will work. So one without the other is something is I think a major loss for both.
We are not saying that e-learning is a solution for everything, but if it can be used as a tool to reach out and build the capacities of health workers, then why not?